Assalamualaikum dear doctors. In this video I am discussing the headache from the NICE guideline. So headache is very important. History is coming from headache. What are the causes of headache? That is viral illness, ENT infections like sinusitis and throat infections and minor head trauma. Primary headache disorders are migraine, tension type headache. Neurological condition that presenting with headache needing urgent attention. These are bacterial meningitis, intracranial hemorrhage, shunt related idiopathic intracranial hypertensions, new hydrocephalus, brain tumor and brain abscess. Assessment of headache. From history, headache is LIQDFOE. So that is location, insensitivity, quality, duration, frequency, other symptoms, any nausea, vomiting, photophobia, dizziness, effect or degree of importance due to headache. Now, associated symptoms of headache are alteration in sensorium, drowsiness or low Glasgow scale, seizure, persistent vomiting, new any visual symptoms like diplopia, abnormal eye movement and visual impairment, behavioral changes, recent change in gait or balance or coordinations, any other neurological symptoms, recent head trauma and systemic symptoms. Red flag. Red flag is always important in headache. So these are the red flag of headache are recent onset of any severe headache, change in headache severity and frequency, early morning or waking from sleep, postural headache, fixed site locked headache or unusual location, ophthalmological symptoms or signs, especially new onset, abnormal growth or puberty, deterioration in school, work or personality, and parental worry. Be cautious of fast and worse headache. Short history of progressively worse headache. See the imaging below. Okay. Examinations. What are the general physical examination of headache we do? These are associated with fever, skin rash, abnormal head positions, torticollis, marked or neurocutaneous syndrome, blood pressure, pulse, oxygen saturation, temperature, weight, height, BMI, pubertal status, scalp, face, neck, oral cavity, full ENT examination. The neurological examination specially look for new onset of squint, cranial nerve palsy, any other focal neurological deficit, cerebellar sign including nystagmus, meningeal signs. In fundus, if uncertain or abnormal, discuss with the ophthalmologist. Imaging is that investigations and management based on clinically suspected cause of headache. MRI brain scan if contraindication to MRI or CT brain. Indications. These are if any red flag present any headache. Difficulty to classify into one of the primary headache, example migraine or tension type headache. Fast or worst headache. Short history of progressively worse headache and presence of new neurological symptoms or signs associated with headache, persistent or recurrent vomiting, balance or coordination problems, abnormal eye movements, behavioral change that is particularly lethargy, seizure and abnormal head position or head tilt. Idiopathic intracranial hypertension. Remember IIH. What is the diagnosis of idiopathic intracranial hypertension? Suspect IIH presenting with papilloedema without 6 cranial nerve palsy causing diplopia, intact the conscious level with any pattern of headache. Features of raised intracranial pressure, these are nausea and vomiting, headache worse lying down with coughing, bending or exercise. Additional features are child waking up in sleep with headache, pulsatile tinnitus, dizziness, ataxia, back or neck pain or stiffness. Now, the common visual symptoms are transient visual loss or blurring of visions. Request ophthalmologist to confirm the papilloedema, obtain color vision and visual field charting. Normal neurological examination except sixth nerve palsy and papilloedema. The causes are obesity, usually association or risk factor. Drugs may be cause contributory factor. Steroid therapy or withdrawal, growth hormone, tachycardia, oral contraceptive pills, endocrine or hypo or hyperthyroidism, hypo or hyperparathyroidism, adrenal insufficiency and Cushing syndrome, hematological or iron deficiency anemia, sickle cell anemia, infections and systemic disorder. These are otitis media, Lyme disease, HIV, chronic renal failure and systemic lupus erythematosus, obstructive sleep apnea and cerebrovenous thrombosis. About the investigations of headache are initial we do the full blood count, bone profile, thyroid function test, urea and electrolyte and parathyroid. Other as clinically indicated. Imaging we do the MRI brain modified of choice. CT brain only if contraindication to MRI or significant urgency for examination. Magnetic resonance venography discussed with the consultant and or radiologist. Lumbar puncture. When the opening pressure is more than 28 cm H2O, normal cell count and biochemistry, CSF pressure can be phasely high or low, falsely high or low. Hyperventilation can reduce the pressure. Distress, anxiety, Valsalva can increase the pressure. Can be performed under analgesia, sedation or general anesthetic. Sedation can increase pressure. in tidal carbon dioxide should be monitored and kept in normal range for LP under the general anesthetic. Treatment. First line of treatment is acetazolamide. Be careful about children with papilloedema. Suspect on routine eye check in an asymptomatic child. Seek advice before starting investigations. Do not diagnose idiopathic intracranial hypertension on high CSF pressure alone in absence of typical clinical features. Now, head injury. So, head injury, when we do the CT scan, less than 1 hour if high risk factor, suspicion of non-accidental injury, post-traumatic seizure but no history of epilepsy, on initial emergency department assessment GCS 14, or for children aged less than 1 year GCS pediatric less than 15, at 2 hours after injury GCS less than 15, suspected open or depressed skull fracture or tense spontaneously, any sign of basal skull fracture, that is hematotympanum, panda eye, cerebrospinal fluid leakage from ear or nose, bruising over the mastoid process, battle sign. Focal neurological deficit. For children aged less than 1 year, presence of bruise, swelling or lacerations more than 5 cm on head. No high risk factor and more than 1 moderate risk factor, CT less than 1 hour. These are loss of consciousness lasting more than 5 minutes witnessed, abnormal drowsiness, more than 2 discrete episodes of vomiting, dangerous mechanism of the injury, high speed road traffic collisions as pedestrian, cyclist or vehicle occupant, fall from height of more than 3 meters, high speed injury from projectile or other object, amnesia, that is antegrade or retrograde more than 5 minutes. None of above and 1 moderate risk factor. These are observed 4 hours after head injury. If during observation any of the risk factor below, CT, head scan less than 1 hour, GCS less than 15, further vomiting, further episode of abnormal drowsiness. If none of above risk factor occurred during observation, use clinical judgment to determine whether longer period of observation needed. If on warfaring with no other risk factors, CT, head scan less than 8 hours after the injury. So this is all about the headache from the guideline. Please do subscribe and share MRCPCH with Dr. Emma Chaudhary. Thank you.